Hello, and thank you for joining us for today's lecture, Understanding Beckwith-Wiedemann Syndrome from Diagnosis to Management, presented by Dr. Jennifer Kalish. I'll cover a few quick housekeeping items and then introduce Dr. Kalish. My name is Zachary Corrigan, Senior Director of Provider Engagement for Children's Hospital of Philadelphia. We are recording today's lecture, and we'll be sharing a copy of the recording with everyone who is joining us live. Second, we do have time at the end for questions and answers. Please post your questions as you have them, but we will be doing questions at the end. You should see a question button in the webinar portal, and that's where you can post your questions. Lastly, for those that will be claiming CME credit for today's event, you will receive a survey after today's lecture. As soon as you complete that survey, you will receive your CME certificate. Now I'll introduce Dr. Kalish. Dr. Jennifer Kalish is a clinical geneticist and physician scientist at Children's Hospital of Philadelphia and the Perelman School of Medicine at the University of Pennsylvania. Her work focuses on Beckwith-Wiedemann syndrome and disorders of growth and genetic cancer predisposition. She wrote the National Tumor Screening Guidelines and co-wrote the first international BWS consensus guidelines. She directs the Beckwith-Wiedemann Syndrome Clinic at Children's Hospital of Philadelphia and the Beckwith-Wiedemann Syndrome Program of Excellence through the Orphan Disease Center at the University of Pennsylvania. Dr. Kalish earned her BA with honors in physics and chemistry from Harvard University. She received her MD with honors and a PhD in genetics from Yale University. She trained in pediatrics and clinical genetics at Children's Hospital of Philadelphia and received a master's in translational research from the University of Pennsylvania. Dr. Kalish's research is funded by the National Institutes of Health, the Damon Runyon Cancer Research Foundation, and Alex's Lemonade Stand Foundation. Please welcome me in joining Dr. Kalish.
Thank you for the introduction. I'm very happy to be here talking to all of you today. So I'm going to talk to you today about many aspects of Beckwith-Wiedemann syndrome, starting with what is BWS, what causes BWS, how do we manage children and adults with BWS, how do we study BWS, and finally, how do we really understand BWS? So what is Beckwith-Wiedemann syndrome? Well, classically, it's described as an overgrowth and cancer predisposition syndrome that affects about 1 in 10,000 live births. We know from recent data that in IVF pregnancies, the impact is about 1 in 1,100. So what is BWS? Well, it was first described by Bruce Beckwith, a retired pathologist, and Hans Rudolf Wiedemann, a pediatrician in Germany back in the 1960s. And what they described was very classic cases, as we understand now, of children who were large in size with large organs. And you can see here Dr. Beckwith's original pathology report from the first case that he saw and the drawing that he did of the omphalocele of that patient at autopsy. Well, what they described were a combination of features of overgrowth affecting solid organs and muscle throughout the body. And those features included macroglossia, in some cases lateralized overgrowth or hemihypertrophy, where one side of the body or one part of the body was bigger than the other. And this was really muscle bulk overgrowth, where sometimes leg length differences were seen as well, but really a muscle overgrowth that was described. Omphalocele or umbilical hernias, where the abdominal wall doesn't close properly. There's also, as we understand it now, hyperinsulinism and overgrowth of the pancreas in the form of pancreatic adenomatosis, which was first described in some of Dr. Beckwith's original pathology reports, and we still see that today in some of our patients with hyperinsulinism. And this is a PET CT of the pancreas with F-DOPA staining, so you can actually see the fluorophore taken up in the pancreas over here. We also see embryonal tumors, most commonly Wilms tumor and hepatoblastoma in children with BWS. And there's also other findings that we see in terms of pathology in the organs, including adrenal cytomegaly, and then in the placenta, mesenchymal dysplasia. There's additional facial features that are linked to BWS, including the nevus simplex, typically on the face, and ear creases. We also know that generally large size can be seen in BWS. But what happens if we don't have some of these classic features? For example, if a child is not large for gestational age, or does not have macroglossia, or really the only presenting feature is some body asymmetry or lateralized overgrowth. Well, it turns out that only about half of the children with BWS actually have macrosomia, and macroglossia is not always present. So we have to think beyond the original clinical description that Dr. Beckwith and Dr. Wiedemann came up with to think about the full spectrum that we see of patients with BWS. So in thinking about what's beyond that classic description, we have several categories that I'll get to a little bit more in a moment, which we classify now based on the international consensus guidelines as atypical BWS, and in some cases what appears to be isolated lateralized overgrowth or hemihypertrophy. And it's really important to understand that not all patients with BWS have all the clinical features that I just showed you. And there's really a spectrum of clinical features in terms of number of features, but even within a given feature, for example, macroglossia, not all children have an extremely large tongue. There's a whole range, and I'll get back to that a little bit later. Additionally, we need to think more about how mosaicism in where and when the genetic changes and epigenetic changes that cause BWS happen, leading to the spectrum. And the corollary to that is that to understand how genetic testing can and should be done in BWS, we have to think about ways to sample the mosaicism in multiple tissues when possible. These new guidelines that came out in 2018 were based on an international consensus and trying to pull together all of the data that was currently out there, realizing that there was definitely gaps in the information that we already have and the definite need to develop more and more detailed information on BWS. So these guidelines defined what we now call the Beckwith-Wiedemann spectrum, which really includes any patient shown to have dysregulation of the 11p15 chromosome region that's imprinted that involves overgrowth in tissues throughout the body, often in a mosaic state. This means that the spectrum encompasses a huge range of phenotypes from classic BWS to much more subtle features, sometimes only lateralized overgrowth, or even sometimes overgrowth of just a distinct organ that can lead to hyperinsulinism. So in thinking about this spectrum, we're really talking about the patients in the middle here, ranging from the more classic features of BWS to atypical BWS and isolated lateralized overgrowth. Keeping in mind that there can be other genetic causes both of isolated lateralized overgrowth that need to be considered, although BWS is more common than some of those other ones. And in some cases, we don't necessarily find a genetic or molecular change in this region, and children may have a clinical diagnosis, but it's also important to think about other syndromes in some cases that are more rare than BWS, but can overlap in terms of clinical features. So when we think about this classic atypical and isolated lateralized overgrowth group across the 4 different most common types of BWS, the details of which I'll get into in a little while, you can see that there's a range of clinical facial features that these children all have. The classic children tend to have more of the large tongues, although there's a huge variety you're seeing even in these 4 children up here. Atypical patients with BWS tend to have more subtle features. And these are the children that often will present with hyperinsulinism or even just an isolated tumor as one of the features that helps drive us towards the diagnosis. They also tend to have some form of asymmetry. And then we have children with isolated lateralized overgrowth or really body asymmetry as the presenting feature. And it's really important as you look down each of these columns that you can see that the same genetic changes, depending on where they are in the body, can lead to 3 different severity of presentations in each of these columns for each of these patients. The same is true if we look at limbs, for example. So if we look at asymmetry in the legs, all of these children have limb asymmetry, but you can see in some cases it's subtle, and in some cases it's more severe. And sometimes that correlates with a leg length difference, and sometimes it does not. So in thinking about the diagnostic criteria for BWS, we now divide them into cardinal features and suggestive features. Some of the classic features, such as macroglossia and omphalocele, are cardinal features, but it's important to note that large birth weight or macrosomia, large size, is now a suggestive feature, not a cardinal feature of BWS, because not all children with BWS have that as a feature. And lateralized overgrowth and hyperinsulinism are both listed as cardinal features here because we have seen cases where one of those things is really the only presenting feature that's obvious initially. Also on the cardinal feature list is bilateral Wilms tumors and some of the pathology findings that I described before in terms of the adrenal gland, the pancreas, and the placenta. It's also important to note that embryonal tumors in general are listed as a suggestive feature, but I'll get to this a little bit later. In our experience, we've seen isolated Wilms tumors or hepatoblastomas as a presenting feature potentially of BWS. The way the scoring system works is you get 2 points for every cardinal feature, and you get 1 point for every suggestive feature. And you want to have at least 4 points for a clinical diagnosis, typically including at least a cardinal feature. Now, I'm happy to talk in more detail about some of the individual features a bit later. It's important to note, though, that things like omphalocele, which can be common outside of BWS, also clinical judgment is really important in trying to determine if testing for BWS should happen or not. If you have at least 2 clinical points here, it's is sort of the threshold for molecular testing, keeping in mind it's helpful for one of those to be a cardinal feature because a lot of the suggestive features are found in the general pediatric population independently of BWS, so those alone may not lead to the diagnosis. So moving on from the clinical diagnosis of BWS into what causes BWS. And there's 3 aspects that we need to think about here, and we'll take them each in turn. These drawings are actually from our educational coloring book, and we want to think about the BWS region, the regulation of that region, and how that affects growth. So in thinking about that, we have to talk a bit about genomic imprinting, which means that in most cases, most genes in the genome are biallelically expressed, meaning that you have a copy expressed from the maternal chromosome and one from the paternal chromosome. But there's a subset of genes in both mouse and humans that are monoallelically expressed, meaning that they're only expressed from either the maternal or the paternal chromosome. And that expression is maintained by imprinting control regions located adjacent to those genes. In this case, the methylation mark is the colored circle on the paternal chromosome, and the open circle on the maternal chromosome indicates there's no methylation. These regions are in multiple places throughout the genome. They're typically regulating genes that control growth, and they're often in clusters. And the clusters that we're most interested in for Beckwith-Wiedemann syndrome is the cluster on 11p15. On that region at the far end of chromosome 11, there's 2 regions. So imprinting cluster 1, or IC1, is located here. And in that region, there's a non-coding RNA called H19, which is an inhibitor of growth. That's expressed from the maternal allele when there's no methylation. When there's methylation at this region, at this particular imprinting cluster, there's expression of IGF-2, which is a growth factor. So you have that balance that's maintained for imprinting cluster 1. Adjacent to that region, there's a second cluster where the methylation mark is actually on the maternal allele, and that imprinting, when that's present, will lead to expression of KCNQ1, over here, which is a potassium repolarizing channel, and CDKN1C, which is a cell cycle regulator. On the paternal allele, there's no methylation, and you have expression of KCNQ1021, which is a non-coding RNA. And it's this balance between the expression of the genes from the maternal allele that actually inhibit growth and those that promote growth on the paternal allele that gives you normal symmetric growth. In BWS, that balance is disrupted. So in the most common type of BWS, there's loss of methylation or hypomethylation at IC2, leading to loss of CDKN1C expression. And that makes up about 50% of molecularly confirmed cases of BWS. You can also have gain of methylation at imprinting control region 1, which makes up about 5% of cases of BWS, and you have biallelic expression of IGF-2 in those cases. Keep in mind, and I'll get back to this point in a few minutes, that these changes happen after fertilization in most cases and are usually not hereditary, and therefore we have a different distribution in different children of these changes and therefore different physical features. And I'll get back to how that works in a moment. The second most common type of BWS is paternal uniparental isodisomy, making up about 20% of cases. And for this particular change, what happens is you lose this part of the maternal chromosome and it's replaced by the paternal chromosome. For most places in the genome, that won't matter, but here, because you need exactly 1 copy of the maternal and 1 copy of the paternal to have a balance of the genes that control growth, you end up with an overexpression of the genes that promote growth and loss of the genes that inhibit growth, because you have methylation here and an absence of methylation here. Another one of the more common types of BWS is mutations in CDKN1C, where methylation is actually not altered, but instead you have a mutation in the maternally inherited CDKN1C gene, and that gene doesn't function. And that in about 5% of cases of BWS, we see that change. This is one of the inherited types of BWS, as are some of the rare deletions and duplications that can affect this larger region that alter the methylation pattern ultimately in this region. So when we think about the overall molecular breakdown of BWS, about half of the children with BWS have loss of methylation, about 20% have a UPD for chromosome 11, and then there's the smattering of other rarer forms. There's also this unknown category, and this data is based off of the international consensus. And what we've learned through our experience at CHOP is that this unknown piece, in some cases, is because we haven't been able to test the right tissue. And if we start testing a more affected tissue, not just blood, sometimes we can actually find the underlying molecular change. So thinking about how epigenotype and genotype and phenotype correlate, we know that there are commonalities within the different genetic or epigenetic types. So for the most common IC2 loss of methylation group, those children tend to have macroglossia and omphalocele. They also have a lower tumor risk. And we know that while there is an increased incidence of BWS in IVF pregnancies, this is the most common group that we see as a result of those pregnancies. IC1 gain of methylation children tend to have a higher tumor risk and more body asymmetry. Children that have chromosome rearrangements, deletions, and duplications present with a more variable phenotype depending on if there's another region outside of chromosome 11 that's involved with that. Paternal uniparental isodisomy for chromosome 11 typically presents with more body asymmetry and hyperinsulinism. They also have a higher tumor risk. And about 20% of children with paternal UPD for chromosome 11 actually have more broad-based uniparental isodisomy that in the form of genome-wide. So it's not just chromosome 11 that's affected, and those children have a similar phenotype but may have other additional features as well. And finally, children with CDKN1C mutations tend to have omphaloceles and have a slightly higher risk for neuroblastoma. So in thinking about these genetic changes and how that integrates into the way children present to us clinically, we have to talk about mosaicism. So when you're thinking about a mosaic, you're thinking about a picture made up of tiny little colored pieces that makes a pattern, and an interesting pattern, whether it's the baseball stadium or pictures of all sorts of other interesting things. But when we think about an individual, we're thinking about a person made up of genetically different cell types. And some of those cell types have changes and some of them do not. And that is what leads to the variability we see in BWS. So how does that translate into genetic testing for BWS? Well, we want to test methylation first. That's the most common thing that is dysregulated in BWS. And the most available tissue to test for us is really blood. So the testing algorithm that we typically recommend is to start with methylation testing in blood. If that's positive, move on to test for copy number to see if there's any deletions or duplications that's causing that methylation difference. If that's positive, then you have an answer and you know that there's some chromosome rearrangement, whether it's big or small, involving chromosome 11. If that copy number testing is negative, you're more likely to have one of the three most common types of BWS, either paternal UPD, IC1, gain of methylation, or IC2 loss of methylation. In cases of UPD, we want to know if it's restricted to just part of chromosome 11, all of chromosome 11, or beyond that, so a SNP array is recommended to figure that out. If testing by methylation in blood was negative, the next test that's recommended is CDKN1C sequencing, since that would not have been covered by the testing for methylation. If that's positive, then we have an answer there, and we can move on to clinical management. If it's negative, we still can think about mosaicism, and if there's other tissues that we can test that are easily clinically available. And our typical approach is if tissues become available based on surgical procedures or other procedures that are happening, then we try and test those samples if possible, whether it's a skin sample during surgery or some other sample that's available. If these are positive, then again, we have our answer. If they're not, we're left with two alternatives, whether there's an alternative diagnosis or we're left with a clinical diagnosis, knowing that we can't necessarily access the tissue that would be most relevant to test. So when we're testing for methylation and copy number, we're literally looking at the marks on the chromosomes by a couple of different techniques that are available at imprinting cluster 1 and 2. Now, it's important when we're thinking about testing for mosaicism, how good each test that we're doing is at detecting mosaicism. And most clinical testing labs, at least in the US, do methylation-sensitive MLPA, and the sensitivity for detecting mosaicism varies by lab, but typically you need at least 10 to 20 cells out of 100 that have the change in order to detect it. One of the things that we've worked on over the past few years with the genetic diagnostic lab at the University of Pennsylvania right next door is to improve this sensitivity using a technique called methylation-sensitive PCR. And for using this technique in this laboratory's hands, we can detect about 3 cells out of 100 with the genetic change. So by improving our detection efficiency of mosaicism, we can find lower level mosaicism in the samples that we're testing. Now, why is all this important and why are we getting this distribution of mosaicism in our patients? It's because of the timing of when these genetic and epigenetic changes happen. Now, if there's an underlying familial cause of BWS, what I'm showing you here doesn't apply. But for non-familial types of BWS, we have a change somewhere in the early cell stage. So this is the 2-cell stage right after fertilization, and we're moving up to more and more cells as we're getting closer to embryo and eventually fetus and child. So if the change happens very early, there's more likely to have more tissues affected. If the change happens even just a little bit later, less tissues are likely to be affected. And what that distribution of tissues or of where these cells are in the child eventually determines what the clinical features are. So now that we've talked about how to clinically diagnose and how to molecularly diagnose BWS, let's talk a little bit further about how we care for children with BWS. And children come to clinical attention for BWS through a number of different pathways. Sometimes they're diagnosed prenatally, sometimes they're diagnosed at birth, and sometimes they only have very mild features and they may not be diagnosed until slightly later in life. So they can be coming in through a variety of different avenues into a medical setting. So it's really important that physicians of all different specialties, whether it's pediatrics or something or a subspecialty, are thinking about BWS in the context of when some of these things can appear, because we don't know if body asymmetry may be the presenting feature, or an omphalocele, or just a slightly large tongue. So we've developed a NICU pathway and algorithm for how we manage BWS that's available at the link listed here. And what we're thinking about here is going through making the diagnosis both based on history and physical examination and thinking about the BWS features that we just talked about and thinking about genetic testing options as well. It's also very important if you're suspecting BWS to consult with a geneticist, especially if you see any of the cardinal features or even multiple suggestive features, and raise the concern about possible BWS. Once the diagnosis is clear or even on the pathway towards that, we need to evaluate and treat based on different subspecialty consults and arrange for appropriate genetic testing on whatever tissues are available to us, and then consider moving beyond the initial hospitalization and how to help families transition to home. When thinking about how we manage BWS, we talked before about the clinical diagnosis. We'll talk a little bit more now about some of the prenatal diagnostic features and then the genetic testing and mosaicism. But there's several broad categories here that we need to think about when it comes to managing BWS. And some of them I'm going to go over briefly here, and then I'll get into more detail about some of them with some examples in a few minutes. So thinking about the omphaloceles, which is a major presenting feature of BWS, there isn't anything specific about the management of how to manage the omphalocele after a child is born that are specific to BWS. One thing to keep in mind, though, because of the mosaicism that we were talking about before, if surgery is planned for an omphalocele closure and BWS is considered one of the possible diagnoses, it would be helpful to save a skin sample at the time of surgery or to collect a skin sample for additional genetic testing if the genetic molecular diagnosis has not already been determined. So, and I will get back to macroglossia, hypoglycemia, and hyperinsulinism and tumor screening a little bit later, but wanted to touch briefly on lateralized overgrowth and the body asymmetry. As I mentioned before, typically the overgrowth we see in BWS is really muscle-based and a muscle bulk difference. But sometimes a leg length or a limb length follows with that as well. And if it's a leg length difference, that's something that needs to be followed closely by orthopedics, typically starting around the time that a child is walking and running, and followed over time, because if in adolescence the difference is greater than 2 centimeters, it's possible that a surgical intervention may be needed to help even out the leg so scoliosis doesn't develop later in life. There also, in rarer cases, can be cardiac and renal differences in children with BWS. And it's important, if there are clinical suspicions for these things, to follow up with the appropriate specialists. It's also important, as we're transitioning to adulthood, to think about evaluation for kidney differences and if they haven't been tracked for several years because we're no longer tumor screening. It's also important to think about, and as may come up in the talk or in questions that you may have, there's a lot still to be studied. So there's a lot more work for us to do in terms of how we improve management for children with BWS. So I'm going to start with a couple of case examples now to give you a little bit more information about how we work through some of these clear and sometimes challenging cases. So this patient first presented with, at 12 weeks, with an omphalocele found on prenatal ultrasound just as part of their normal screening. They were referred to Children's Hospital of Philadelphia through the special delivery unit at that point, and at 20 weeks were found to have some cardiac changes involving the pulmonary valve on fetal-echocardiogram. Ultrasounds prenatally also revealed placental megaly and placental mesenchymal dysplasia, and a possible diagnosis of Beckwith-Wiedemann syndrome was suggested at that time, and the family chose not to do additional prenatal screening, but decided to deliver at CHOP, and the baby was born at 34 weeks. The birth weight was quite large, and a large umbilical cord was noted at delivery. So, and I actually had the pleasure of meeting this family right after birth and made a clinical diagnosis very shortly after birth. We actually, based on work done by a group in Italy that we've collaborated with, there's now a clinical scoring system for prenatal BWS. And it's similar to the scoring system I showed you before for children and infants in front of you. And it's divided into major cardinal features, suggestive features, and there's a few supportive features that don't show up in the international consensus scoring system related to things that can be found in pregnancy, particularly history of ART, twinning, and elevated serum screening that can happen early on. And it's really interesting to see how this plays out in both pre and postnatal scoring. So for our patient, he would have scored a prenatal score of 11 points based on the clinical features that we are aware of prenatally. So moving on a little more in his story, he also had hyperinsulinism detected at birth, which couldn't have been detected prenatally. His genetic testing on blood showed loss of methylation at IC2, the most common type of BWS. And we initiated his tumor screening, and at 6 weeks detected a hepatoblastoma, which was treated with chemotherapy and surgery. And I'm happy to say that at 5 years of age now, he is doing extremely well and enjoying kindergarten. He also had a tongue reduction at 1 year of age. So going back to the scoring system to see, after all of that additional information, he actually has a clinical score of 16 points, which is higher than the prenatal score, but in both cases was enough to suggest that both a clinical diagnosis, but also to do additional testing. So moving on to another patient, and this patient had prenatally detected macroglossia that was found at the 28-week ultrasound, and there was also nephromegaly and hepatomegaly detected at that point, and mesenchymal dysplasia of the placenta. This little girl was the product of an IVF pregnancy, and there was also polyhydramnios. This family opted to have prenatal testing and were found to have the most common type of BWS. Keep in mind that nothing was really suspected until that later ultrasound, and the prenatal score was 11. Postnatally, her score was actually 11 as well. And so in this case, the prenatal and the postnatal scores matched up, and she had clinical features as described here. This brings up the question of what is macroglossia and how do we determine that? One thing I didn't mention about this patient is that she actually had a tongue reduction at 7 days of age and we suspected that her tongue would be quite large based on the prenatal findings as well. So what is macroglossia? Is it something that fits in the mouth or doesn't fit in the mouth? Because when you look at a child, it's a dynamic state. And how do you determine who needs a tongue reduction? Because if the tongue looks like this, it's there, but it's not really that far out. But sometimes it can also be very far out. So to try and assess this better and to determine whether or not it was useful to do early tongue reductions and what the appropriate algorithm was, we looked at a number of patients that we had in the BWS registry to try and figure out what the best approach was to determine how to and when to do a tongue reduction. So in thinking about this, the first question is there macroglossia at all? Because not every child with BWS has it. If there is, if it's prenatally noted and there's a postnatal need for respiratory support or snoring, it's important to do a further workup. And that includes a sleep study and feeding and speech and plastic surgery evaluations to consider whether or not an early tongue reduction, if there is either significant OSA or obstructive sleep apnea or significant feeding issue. If that's not the case, then we want to continue monitoring and feeding and looking at progress over time. So it really depends and has to be tailored for each patient. So moving on to hyperinsulinism, our third patient here was born at near term with a large birth weight and had a very high glucose infusion rate needed. She did not respond to diazoxide, which is a medication that works on the potassium channel in the beta cell, and was found to have a mutation in one of the genes that makes up that potassium channel. On exam, she had slight body asymmetry, and testing showed paternal UPD for chromosome 11 in some of the tissues tested, but not all. So in her case, we actually had, because she required a partial pancreatectomy, we actually had affected pancreas in addition to blood and skin samples. And you can see the mosaicism here by the number of BWS cells in each sample type compared to the normal cells. And it's interesting, in her case, her blood was positive, but her skin was negative. And her clinical score was not particularly high because her only two cardinal features were lateralized overgrowth and hyperinsulinism and a large birth weight. She really didn't have other suggestive or cardinal features of BWS. So our approach to management of hyperinsulinism in BWS, and in general, thinking about neonatal hypoglycemia in BWS, is really to monitor closely initially. And if hyperinsulinism is determined, it really depends on the type of BWS, the molecular cause, as to how severe it's going to be potentially. So having that information can be very helpful. It's also important to know whether or not the potassium channel of the beta cell, which is made up of the two genes ABCC8 and KCNJ11, is functional, and whether there's mutations in those genes. It turns out that the gene location for both of those genes is on chromosome 11, very near the BWS region. So we understand that there is interplay with that. It's also important to determine if the child is diazoxide responsive, because if they are, they won't necessarily need escalated care. If they're not responsive, then we need to consider additional evaluation and therapies, which could involve a PET or a CT or a PET MRI to determine the extent of the pancreas involved, and perhaps in some cases a total pancreatectomy. And there's more information available on our website about how to manage hyperinsulinism and in general and in BWS. And moving on to our fourth patient, this is a patient who presented at 7 months of age with a Wilms tumor, and she had a nephrectomy followed by screening. When we met her a little bit later, we found that she actually had subtle asymmetry, where one leg and one arm was slightly bigger than the other, but very subtle. She continued having tumor screening, and at 20 months, the tumor was detected in the other kidney, and she had a partial resection. Genetic testing of tissues showed that she had in some tissues a gain of methylation at imprinting control region 1. So if you look here at the different tissues that we tested, in blood you can see that there were no BWS cells that were detected. In skin from the larger side there were some. In the normal kidney sample there were some. more. And then finally in the Wilms tumor, there was the largest percent of BWS cells. So this really demonstrates why it's so important to test multiple tissues if you have access to them, because the blood, which is the typical sample that we would test, was not positive in this patient. We have seen other patients with a similar clinical scenario where the blood is actually positive and even sometimes skin is not. So it's really important to test all tissues that are accessible to you if possible, if you're considering BWS in a case like this. And if you look at her initial clinical score, because she only had a single Wilms tumor, she only had a clinical score of 3. But after her second Wilms tumor was found, it moved up to 4. Regardless, because she had a molecular diagnosis, she still fell under the BWS spectrum. But this was very much an atypical BWS case. And also demonstrates really the importance of the mosaicism across tissues and thinking about that when you're seeing a patient or caring for a patient with BWS. So in thinking about both of these two patients, our diagnosis and testing strategy is really if we see patients with either hyperinsulinism or with Wilms tumors and even hepatoblastomas, we want to think about other features that could be suggestive of BWS. And we encourage other specialists to do the same and consider a genetic evaluation and additional either imaging or tissue sample diagnosis to help along the way to try and figure out if this is BWS. And most importantly, sending samples from all available tissues for methylation and or microarray depending on the scenario. And thinking about this kind of approach and looking at our BWS cohort compared to, this is the consensus cohort and the breakdown of molecular types that I showed you earlier, our cohort is a bit different. And that's because our cohort really spans that whole spectrum of BWS. And within the molecularly confirmed cases in our cohort, you can see it's similar, but a little different to the consensus cohort. But when you look at the tissue positive patients, it's extremely different. And that tends to be because more of the UPD patients tend to have this tissue mosaicism more subtly than some of the other cases. So thinking about genotype, epigenotype correlations for tumors, there is a range. And we know children with loss of methylation tend to have the lowest risk, whereas children with gain of methylation in IC1 have the highest risk. And children with paternal UPD are kind of in the middle. And it's really important to think about that, although in the US we do all tumor screening uniformly, such that we follow the American Association for Cancer Research guidelines, which based on an acceptable risk of 1% as a threshold for screening for tumors, we screen all patients with alpha-fetoproteins every 3 months until the 4th birthday and abdominal ultrasounds every 3 months until the 4th birthday as well, and then renal ultrasounds until the 7th birthday. For children with CDKN1C mutations, because there is a slightly higher risk potentially for neuroblastoma, we do additional screening in those patients only. Keep in mind, these are different from the international consensus guidelines, largely based on including the AFP and what the acceptable risk is, which is different between the US and Europe. And that has to do with what we determine as the threshold that we were willing to accept in terms of screening. It is important as you're doing tumor screening to consider the factors of healthcare environment and the access to care when implementing these guidelines. And there has to be a mindfulness towards the type of medical practice, whether it's socialized or private, in implementing these guidelines as well. One of the questions that often comes up is how do we interpret AFPs? And it's really important to think about them looking at the trends over time more than the actual value. And knowing when you have greater increases, when to actually implement additional screening or additional repeating the values versus escalating care. And it's really when you have larger jumps in values that you want to be considering additional imaging initially. In order to develop normal values for AFPs in children with BWS, we actually used the BWS registry to determine this. And we found that there wasn't a difference based on gender, but the norms did differ based on prematurity, even after correcting for gestational age. But there wasn't a difference based on laboratory and everything normalized by around 13 months. So here you can see that prematurity does make a little bit of a difference. And in addition, the genetic type of BWS did not affect the AFP levels. We've also developed normograms that are available on our website to help interpret AFPs. In addition to the AFP and ultrasound management, annual exams or biannual exams between the pediatrician, a geneticist, and or an oncologist or cancer predisposition specialist are recommended. We also recommend doing all the screening at the same laboratory if possible so that you have access to previous results for comparison. Additionally, screening can be performed locally by pediatricians with guidance and support from specialists familiar with the syndromes. And it's really important to tailor this practice towards what is locally acceptable and feasible for families and working together with families. One of the things that was brought to our attention is how families are feeling about tumor screening. So one of the studies that we did a few years ago now was a parent-directed survey really looking at attitudes and feelings towards tumor screening. And this involved a number of surveys completed by about 260 families over several months. And what we learned from this is that tumor screening tend to lessen worry for families, but knowledge of the tumor risk and the genetic type of BWS if parents understood what those things were for their children, it helped them lessen their worry about tumor screening, basically knowing what to expect. So as we think about and try and improve the way we do tumor screening, a study we did in the past year or so with a group in Italy looked at the age of diagnosis of hepatoblastoma. And what we found was that the age of occurrence is earlier in BWS compared to non-syndromic hepatoblastoma. We did a similar study in Wilms tumor, also looking to see whether or not screening was effective. And again, we saw earlier diagnosis in BWS compared to patients without BWS. And for patients who were screened, we also saw an earlier diagnosis compared to patients who were not screened. So screening, at least for Wilms tumor, appears to be effective. So how do we study BWS? Well, in 2014, to really try and improve how we understand BWS, to improve clinical and molecular care, and understanding of the processes that lead into BWS, we developed a registry. Since then, hundreds of families from all over the world have joined, and some of the new guidelines and information I've shared with you today is based on what we've learned from the BWS registry. The registry is ongoing and open to all families and patients with BWS. So here's where we started, and here's where we are now with the BWS registry. So thinking about BWS and talking about the molecular and the clinical features, the next question is really, how do we understand how we move from growth to overgrowth to cancer? And how does that transition happen? And what can we learn about that process to try and prevent it or to understand how to manage it better? So in order to do that, we've derived the first cell-based model of BWS using human samples. So we're using skin fibroblasts taken from some of our patients. We took those fibroblasts or skin samples, grew them in culture, and then we're able to turn them into something called induced pluripotent stem cells. And this basically means we turn them back in developmental time in a dish. And then we're able to turn those cells that were induced pluripotent stem cells or iPS cells into liver-like cells. And to be able to study the pathways that we see in children with BWS as the liver is developing. Now, one of the advantages of using BWS samples, because remember the patients are mosaic, we were able from the same patient sample to derive both normal cells and BWS cells from the same patient. So these cells, except for the BWS piece, are identical. And what we found in studying this is that there's differences in gene expression compared to the controls and the BWS cells. And you can see based on the red and blue patterning here, you can see genes being either upregulated or downregulated, and you can see that there's clustering that is different between the controls and the non-BWS cells and the BWS cells. And we start looking at specific pathways. It's complicated, but we do know that there's clustering of genes in pathways that regulate cell cycle, in pathways that regulate cell proliferation and growth. And while there's a lot more work to be done, this is our first clue into some of the pathways that may be involved in that transition between normal growth, overgrowth, and tumor. So in thinking about the BWS spectrum, we've talked about the concept of more BWS cells in children that are more affected. We've talked about the range of different genetic and epigenetic types of BWS and how that can manifest into the phenotype, and the fact that we can see tumors across the entire spectrum. We've talked a bit about the different cardinal and suggestive features and how not every child with BWS may have every feature, and there can be a range of entry points into a diagnosis of BWS. And finally, in conclusion, we need to think about the BWS spectrum and understand that because of the mosaicism of when the genetic and epigenetic changes happen in BWS, it presents clinically as a spectrum, requires really a tailored management for children with BWS. And there's really a lot more that we need to learn. And one of the ways to do that is through the BWS registry and understanding more and more about many, many, many patients with BWS. And finally, we're starting to have clues of this transition between normal growth, overgrowth, and cancer. And I'd like to take a moment or two to thank the team at CHOP and Penn who've contributed to this work both clinically and on the research side through across a multitude of disciplines. I'd also like to thank the patients and their families for participating in this research, my research team and the BWS registry team, are all our collaborators at various institutions around the world, and of course Dr. Beckwith for getting the ball rolling on all of this, and our funding and sponsor support, which without their support, none of this would be possible. And I'd like to take this opportunity to invite everyone to a future symposium on BWS coming this summer in July, and also welcome questions from anyone in the audience and provide a little bit more in terms of resources and ways to contact us or some of the information that I've presented today through our coloring book and our websites. We look forward to hearing from you, and I'm happy to take any questions.
All right, thank you so much for that presentation, Dr. Kalish, and thank you to everyone who's tuned in. My name is Evan Hathaway. I'm the genetic counselor here in the BWS program at CHOP. I'm just going to start going through the questions here, and as we approach the 3 p.m. Cutoff, if you have to leave, don't worry, we won't be offended. But just as a reminder, this recording will be posted later, so if you have to jump off and we're still answering questions, you can always catch up and watch the recording later. So Dr. Kalish, I think a good question to start with, as it will most likely be helpful to all of us on the call, is a question asking if there is a guideline somewhere that summarizes all the risks, symptoms, and signs associated with BWS. It's coming from someone who just wants to make sure they're not overlooking anything.
So is the question about all of the features of BWS?
Right, all of the features, things to be looking out for, signs, symptoms.
So I would say that on our website, there actually are, there is that checklist that I showed you of the cardinal and suggestive features is there, and a number of different management recommendations are all posted on our research website with downloadable PDFs in a couple of different languages. So I instruct you to go there to look at that. And the last slide actually had the link on it, so that will be on the slide deck when it's posted as well.
Thank you. Is there a link between kidney reflux or pulmonary stenosis, BWS?
So kidney reflux. Okay, so there can be all sorts of kidney abnormalities seen in BWS, including reflux, depending on the shape of the kidney. It's not a specific thing that we see in lots and lots of patients with BWS. And then pulmonary valve stenosis was the other part of that?
Yes. Mm-hmm.
Again, we've seen it in some patients, but it's not something, the cardiac features in BWS tend to be pretty variable, and many children with BWS don't have any cardiac features. So I think it's important to manage each one and see a cardiologist if you're concerned about one of those things.
Okay, thank you. And a question on placental mesenchymal dysplasia. Can that be detected prenatally?
It sometimes can, depending on the images that they get of the placenta on ultrasound. But it's most commonly a histologic diagnosis under a microscope after the child is born.
Okay. Up to what age can we see hyperinsulinism? Does it often resolve after age 1 or 2 years?
HI tends to resolve faster in children with BWS overall, usually by around age 2, but not in every case.
Okay. Are children with BWS at higher risk for benign tumors in the kidneys and liver?
We certainly see a range of just growths there, whether it's cysts or hematomas or other things. So there is an increased risk. They haven't been as well quantified as the Wilms tumors and the hepatoblastomas.
Okay. And here's one that I think we would maybe even say we have the same question a little bit, but this person is wondering, they would love to know more about teenagers and adults with BWS.
It's a great question, and it's something that we're actively working on. There was one paper published by the group in Italy that we collaborate with, and we actually have a forthcoming study as well, looking at different features of that. And the common things that we see both anecdotally and sort of came out of both of those, we're thinking about kidney stones and gallstones and scoliosis, especially in folks who who have leg length differences that wasn't necessarily treated in adolescence. So those are the main things we think about, but we welcome collaboration to try and do even more intensive studies about that, because I think it is something that's still lacking in the literature.
Okay, thank you, Dr. Kalish. So this question might be a little bit about terminology, but what does a gain in H19 mean, and what are the risks associated with that?
Okay, so I'm assuming it means a gain of methylation in the H19 region. So if you remember, there was 2 regions that I showed you. One of them, the IC1 region, is the region that has H19 in it. So extra methylation on the maternal allele leads to loss of expression of H19 and expression of IGF-2, the growth factor from both the paternal and maternal.
Okay. Does the risk of Wilms tumor change in the future if you've already had bilateral Wilms tumor? Does it stay lower or stay the same?
It's a great question. I can't say that there's lots of patients that we followed over long periods of time with bilateral Wilms tumors to see how, if they developed additional tumors. I would say there probably is an increased risk for anybody with BWS, because we don't know how many BWS cells are left in whatever is still with the kidneys that are still there. So I think that there's probably tumor screening guidelines that are going to be recommended based on your oncologist recommendations, and beyond that, typically after you age out of those recommendations, you need to follow the ones for BWS.
Okay, thank you. We've gotten a couple questions about development and behavior, so I'll just sort of combine them here, but any links to learning difficulties or behavioral things like ADD and other things like that?
It's something that we're actually in the process of trying to understand more about. And I don't know, we did do it over the summer, a family-based survey on development and behavior that we are still working through the data on. And while there aren't any definitive, everybody has one thing, there clearly may be some differences there that are more subtle than was previously understood. So stay tuned for more information.
All right, we will. This is a question that we've been getting a lot outside of this presentation as well, but are children with BWS at a higher risk if they get COVID?
It's a great question, and yes, it has come up a lot. So early in March, I sat down with some of the folks in Europe who are the experts in BWS over there, and we came up with a few recommendations regarding COVID. And the things that we were thinking about were if there was prematurity, if there's airway issues, including macroglossia that's ongoing, or if there's a reason to be immune compromised, there probably is an increased risk, but not specifically for COVID, but for any viral illness. So if you do have concerns, it'd be important to call your practitioner and discuss them with them and see if they feel your child's at an increased risk. It's not the BWS specifically, it's more the other things that may come with it.
Okay. Can adults with BWS have children? And then a part 2 to this question, do their children have BWS?
So yes, adults with BWS can have children. It depends, and whether or not their children will have BWS depends on the type of BWS you have. So if you have a type that's just a change in the child, it's not necessarily something you can pass forward, but it's really important if you're thinking about having children, or if your children with BWS are getting to an age when they're thinking about that, to think about if you don't know the genetic type, that's a good time to try and get tested so you can have more information in terms of counseling for having children.
Okay, thank you. This question is a little bit more specific in the way it's phrased, but I'll make it a little broader. Can we see differences with genitalia in BWS?
Not typically. Like there's often inguinal hernias and things like that can be present, but not specifically in terms of concerning or ambiguous genitalia, typically in BWS. That being said, there may be some rare instances because of other chromosome interactions. If it's chromosome 11 interfering with another chromosome, that could lead to something like that.
Okay. Are there any increased risk for malignancies in adulthood?
The published study didn't really find a significant increase in any one particular thing. So we know with children with BWS, there's the increased risk for Wilms tumor and hepatoblastoma. So there's one type of thing that we look for and we can screen for. For adults, it doesn't seem to be that there's just one thing that's out there, and it's not necessarily much higher than the general population.
Okay, thank you. We got another question about tumor reoccurrence. This one is about hepatoblastoma. Is there an increased risk of recurrence in BWS?
If you've already had one?
If you've already had one.
Yeah, so I mean, there is probably always a slightly increased risk because we know that you had one in the first place. That's one of the things that we're really trying to understand at the molecular level and in the laboratory, really trying to understand what triggers that and why some children get hepatoblastoma and some children do not. So there probably is a slightly increased risk, but it's, again, should be followed based by your oncologist and then by BWS guidelines once oncology has graduated you.
Okay, thank you. Can you talk a little bit more about the cardiac features or cardiac implications that we think about with BWS?
So the challenge with the cardiac implications is that there's a huge range, and it's not all one particular change that we see. So it's not like everybody has a large something, or so it makes it much more variable. So the typical recommendation is if there's any clinical concern for a cardiac difference, then that should be evaluated further. But without a clinical concern by your pediatrician or what other specialists are seeing you, you don't necessarily need a further workup.
Okay, thank you. Is there any association between hemangioma and BWS, either external on the skin or internal that have been picked up on abdominal imaging?
Yes, we see both. It's not a cardinal or suggestive feature, but we certainly see them in the liver a lot, and you can see them on the skin as well.
Okay, thank you. Does the tongue continue to grow after a certain age, and what is the optimal age for a reduction?
So the tongue, basically thinking about all of those genes I showed you, H19, IGF2, CDKN1C, in the BWS region, those genes are typically on during fetal development and in the first few years. And how they affect different tissues is different, and that's one of the things in the laboratory we're really trying to understand more now. But what we typically see is the biggest incremental growth in the first 6 months of life after birth, and then the second biggest increase in the second 6 months. In terms of the optimal age of tongue reduction, it really depends. We basically see 3 different groups of patients typically: children that can never go home from the hospital the first time without an intervention, children who can go home but have some obstructive sleep apnea or some feeding issues in the next few years of life, or the next year or so of life, that actually need an intervention, and then children who don't have any issues there but have issues with jaw development a little bit later. So it's really important to see a specialist who's familiar with BWS and has expertise in tongue reduction to try and assess what the best timing is for your child or your patient.
Okay, thank you. And we just got a sort of a follow-up one based off of what you were explaining there. In regards to the jaw, is there a point at which we could say, if we're not seeing something, that it's likely not causing an issue. So is there a certain age where if there's no underbite or overbite, are we at a point where it's reassuring that a tongue reduction will not be needed?
Yeah, I mean, I would say probably sometime in childhood, but the challenge with that is we don't have good studies on large numbers of people or children even with BWS where we're actually following that over time in a very rigorous way. So anecdotally, probably in early childhood, but it really it just depends, and it depends on the shape of the teeth and the way the teeth come in. And sometimes orthodontia is sufficient and you don't need a tongue reduction, but it really depends on the child, and it's really important to just follow that closely over time because with the same physician if possible, because that way they have a sense of how the child is progressing over time.
Okay, thank you. What is the treatment for diastasis recti? Does it depend on the severity?
Sorry, say that one more time.
What is the treatment for diastasis recti in BWS babies, and does it depend on the severity?
Yeah, I think it does depend on the severity. There isn't a typical treatment for it. Usually children outgrow it. I think in severe cases, there may need to be a surgical intervention, but typically over time, there's strengthening of those abdominal wall muscles and the muscles do come together.
Okay, thank you. Question about the conference, where will that be?
It will potentially be in Philadelphia. There will definitely be a virtual component to it, and we are still working out the details of that. I imagine registration will open sometime in the new year, and we will have all of that hammered out.
Okay, thank you. Here's sort of just a general question. At what point, when a diagnosis of BWS is being questioned or considered, should tumor screening begin?
Great. So we typically begin tumor screening as soon as we're considering the diagnosis. So if we're seeing a patient in clinic and we're sending testing, we will do an initial tumor screening and go from there. Okay,
thank you. And at what point should someone be referred to genetics? Whether you're a provider you have a patient that you're considering a diagnosis of BWS, or maybe you're a parent questioning, at what point should you think about going to genetics?
I would say as soon as you're considering the diagnosis. So if the question's been raised, I think that's the time to refer, because it's important to bring in folks who have expertise in this to try and assess whether or not it is BWS or not.
All right, thank you. And at the moment, I think we've worked our way through all of the questions that have come in. I apologize if I missed any, but I think we've answered what we have received so far.
So this was a fantastic lecture, Dr. Kalish. You are fast on your feet. That was incredibly impressive that you were able to get through so many questions so quickly with such detail. So we greatly appreciate everyone's time today. If we somehow did not get to any of the questions, we do have a log and we'll be able to follow up with everyone offline. And we appreciate everyone's time today. Thank you so much.
Great. Thank you, everybody.